Hello, and welcome to the Nursing Economics podcast series. This series provides extended content relating to articles published in the journal, such as interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net, click subscribe, and enter promo code NECSAVE50 to take advantage of this special discount. In this episode, Nursing Economics Editorial Board member Dr. Therese Fitzpatrick talks with CEO and nurse leader Dr. Sheila Davis about the global impact of COVID-19 and how the pandemic has impacted vulnerable populations. In addition, the role of nurse leaders in advancing social justice, developing community capacity, and addressing detrimental health issues worldwide is also discussed. We are pleased to present this important conversation between Drs. Fitzpatrick and Davis.
Hello, this is Therese Fitzpatrick, and on behalf of our editor, Dr. Donna Nikitas, and the entire editorial board of the journal Nursing Economics, I would like to welcome you to this latest edition in our podcast series. Today, we will be continuing the conversation around the global impact of the COVID pandemic and its significant effect on vulnerable populations. We will also explore the role nurse leaders are playing in advancing social justice, developing community capacity, and addressing the most pernicious health issues worldwide. The past 2 years have been testament to the fact that disease knows no borders, and we are inextricably connected as a global community. Nurses are experts in building community capacity, forging strategic partnerships, advocating for our most vulnerable, and developing systems of healthcare. Today, I have the honor and pleasure of introducing one such global nursing leader. Dr. Sheila Davis is the CEO of Boston-based Partners in Health, a global organization of 19,000 health professionals, scholars, and activists, collaborating with national governments to provide care and strengthen public health systems. I am going to ask Dr. Davis to say a lot more about Partners in Health, but before I do, let me introduce our esteemed colleague. Prior to becoming CEO, Sheila served as both the Chief of Clinical Operations as well as Chief Nurse, Director of Global Nursing, and Chief of Ebola Response for Partners in Health. In her role as Chief of Ebola Response, she collaborated with multiple federal agencies and the governments of Sierra Leone and Liberia in their response to the crisis. She represented Partners in Health at both the UN and the World Health Organization. She has been a visiting lecturer at a number of universities in the US as well as globally. Sheila is a fellow in the American Academy of Nursing, received Living Legend recognition by the ANA Massachusetts. She's a RWJ Fellow and the recipient of a Lifetime Achievement Award of the Association of Nurses in AIDS Care, to name a few. Her scholarship, including consultation, research, publication, and community service, focuses on global health issues, HIV and AIDS, and building community capacity. Dr. Davis, on behalf of Nursing Economics, welcome. Several hours would be required to fully explore your storied career. However, today we would like to gain your insight in several specific areas. Learn more about Partners in Health and your important mission, and a bit about your experience leading the Ebola response and how we might apply those learnings in the current pandemic. The crucial role nursing leaders play in global health And finally, a bit about your personal career trajectory and lessons for our emerging leaders. That's a pretty full agenda, so we'll dive right in. So let me start by asking, can you tell our listeners about Partners in Health, your important mission, and the partnerships that you have forged worldwide?
Yes, thanks so much, and thanks for this opportunity to be with you today. Partners in Health is a social justice global healthcare organization, and we're a nonprofit or non-governmental organization, and we've been around since the mid-1980s, started in Haiti by a small group of young people who really wanted to develop an organization that addressed those living in poverty and what we can do to provide a medical and a clinical mission or a clinical response to that. So we consider ourselves, we're not a religious affiliate organization by any means, but we're all very much driven by providing a preferential option for the poor. And that means where we've worked for 35 years is all places of really abject poverty. And where our partnerships and how I think we're a little different is we don't go in and set up parallel systems, as there's a lot of well-meaning people globally who have built their own hospital or built their own clinic or fly in a couple times a year. And I think what we've seen is that the way that you can really provide long-term healthcare is by partnering with the public sector, which is partnering with ministries of health, partnering with governments, partnering with those community-based organizations that are already there. So wherever we go, we stay long-term. And our goal is to provide healthcare and provide, high-quality healthcare in places that don't have it, but also build the health system while we're there and build capacity by training the next generation of healthcare providers so we can change the long-term dynamic of what's happening. So advocacy and really showing what can be done in settings is a big piece of what we do.
Thank you. Boy, how interesting. And certainly in this day and age, there is much more need, I'm sure, than capacity to be able to deliver. So can you tell us how you have leveraged your expertise as a nurse leader and scholar in your role as Chief Executive Officer of this organization?
Yes, I think I was a surprise for everyone in terms of being chosen for the next CEO. Probably nobody more than me, to be honest. And what had been a leader within the organization for about 9 years and never thought that a nurse would be chosen as CEO as a Harvard affiliate NGO or academic NGO, but was asked to put my name in the hat and wanted my ideas to come across. Certainly not my own unique ideas, but from living and traveling with people in 11 different countries around the world, when we stay up late and we see things and having learned from so many people, I really had some ideas of how I thought we could be run differently or how the organization should shift. And, at each round of the interview process, I kind of was still there standing. So it was surprising to, again, as I said, me more than anyone. And, I think why I was chosen and have so far, I think, been successful in this role is because I'm a nurse, because I'm a systems thinker, because I build good teams, because I listen more than I speak, because I really know that you have to listen to people who are in the most proximity to what you're trying to deal with. Just like we listen to patients at the bedside, we need to listen to communities in rural Haiti, for example. And those are all skills I learned as a nurse. Certainly also, our ability to multitask, to constantly triage, that is what makes us nurses successful. So I think by being able to address and look at a problem as human-centered, even though it's a big, huge NGO, it's the human part of it. And I think that's where the skills that I think are needed for CEOs, very much we learn as a nurse.
Oh, thank you. Thank you for sharing that. Well, I know that everyone listening into this call is anxious to hear about your experience leading the organization's Ebola response. Can you talk to us about what that looked like, what it felt like, and what was your role, both in terms of leadership, and I also know that you were on the ground, actually, helping to sort of supervise that response at ground level. So I'm going to turn things back to you to tell us about that.
Yeah, so Partners in Health, we're not an emergency organization, although we respond to emergencies all the time in the places we work. We just responded to the recent Haitian earthquake and, mudslides in Sierra Leone and fires and floods in Malawi. Wherever we work, emergencies happen, and our places we work are disproportionately impacted by emergencies because they're places of poverty. So the impact is huge. So we hadn't been working in West Africa. And then when the world was really not paying attention to what was happening in the summer of 2014, we started to be listening. And particularly since many of us, myself included, was trained in infectious diseases, my background being HIV, but our founder, Dr. Paul Farmer, is an infectious disease physician. And so I think we're always in tune to infectious disease. And we saw that the world was not responding and saw that there was a moral imperative that people needed to go and help. And so, because we knew how to deploy clinicians, because we did so post Haitian earthquake, and we've done so in other circumstances, we decided as an organization and got approval from the board to go. Very soon after that, I volunteered to lead this. And for a few reasons. One, I didn't have little kids at home, and we were all very scared. I also knew as a nurse, because I could address the systems, that I could be okay at this and was willing to jump in and do this. So we started working in Liberia and Sierra Leone. We're later asked to go into Guinea, the third country that was impacted. But by then we were at capacity. We had to say no. So we, do what we always do, which is our model, is we partner with communities on the ground. And so we, unlike other NGOs who kind of set up their own response, and we learned from our partners like MSF and others who had treated Ebola before and we hadn't. So we were trained by them, but we partnered with the Sierra Leone government, and they had their own Ebola treatment unit that was set up. And no other NGO wanted to work in that treatment unit because it was very unsafe, frankly. And, we had, and particularly me as a leader on the ground, had to make a decision based on, do we build our own tent, treatment unit, which would be 3 to 6 weeks, or do we join forces with our Sierra Leone colleagues and make that Ebola treatment unit, it was called Maforki, a safer place. So it was a tough decision because I knew that I was putting our staff at higher risk, but the moral imperative was to not leave the Sierra Leone colleagues by themselves who were dealing with us at this time. So we joined and started working in Maforki with the Sierra Leone Ministry of Health and made it better from within, and ended up having a very successful treatment unit and treated thousands of people. And I think that was sticking to who we are as an organization, because we don't go and start our own parallel system. We also went in knowing that Ebola was a symptom of a broken health system. So Ebola, the only reason why it didn't take off in Texas when that poor soul from Liberia was infected, and there were a few nurses who were infected after that from that facility, but the reason why it didn't take off is because we have a functioning health system, and they didn't have that in West Africa. There had been a study 2 years before, I believe, that looked at what would it take to strengthen the West African health system. And I think the quote was like 1.2 billion or something. And this was pre-epidemic. And of course, that was too expensive for the world, so nothing happened. And then $4.3 billion was spent during Ebola, and no health system left behind. So we went in knowing that we were going to stay. So at the same time we were working in an Ebola treatment unit in Maforki, we also started strengthening the district hospital nearby, because when people got discharged, some people no longer had Ebola, but they were too weak. And so we were going to send them home to be in a community by themselves. No, so we put half our clinicians in the hospital and started building that hospital up, which is our overall goal, putting in water, electricity, putting in blood banks, doing the things that kind of the foundational care that we need. So, when Maforky closed, we were still there. We're still there long term. We're building a big maternal center of excellence to combat maternal mortality. Sierra Leone has one of the highest rates of maternal mortality. And I'm proud that that's how we approach even emergencies, of looking at what is the root cause of why the devastation is so much worse in places. And it is because there's no health system. So our whole goal is, even during emergencies, is what can we do to build up a different system? But Ebola was challenging as a leader. It was scary, providing care. And I only went in the Ebola treatment unit a handful of times, but it's scary. And I knew as a leader, I often had to make tough decisions about, knowing that if we didn't have enough staff who were there at night, is it safe to go in? And we did go in at night, and we did work to get electricity so it was safer. We did do IVs, although it was a higher risk to do IVs, because putting in an IV in that full kind of PPE is certainly challenging. But we knew that although it was higher risk for our staff, we needed to be able to save people, and that was by fluids. So I think it was a lot of challenges, and we worked closely with the Liberian and Sierra Leone government, as well as other NGOs, but really tested myself as a leader in being much more decisive about making decisions, still trying to have consensus as much as possible, but also knowing that I had to make decisions about, we need to get this water, we need to get this chlorine, we're going to pay this money to do this and do that. So stretched far beyond of what I had ever done previously as a leader.
Oh, my goodness. So interesting. So as you reflect on that experience, what lessons can be applied to our current pandemic response? I'm sure you've thought about that lots in the last 2 years.
Yes, and when we've responded to COVID globally as well as in the U.S. So we didn't really have a presence in the U.S. other than we've worked in Navajo Nation for over a decade. But we consider Navajo Nation a sovereign nation, so we don't consider it a U.S. site. But during COVID, we were asked to work in the state of Massachusetts and launched a contact tracing program. And then we ended up working in another 16 places across the U.S. in different ways. But I think that we brought the lessons learned from Ebola, from multi-drug resistant TB, from cholera in Haiti, in that you have to have a comprehensive approach. You can't just do one piece of the puzzle. So when we started initiating with the state of Massachusetts and the Department of Public Health, our contact tracing program, we really said we have to address the core components of what people need. So we initiated a care resource coordination role so that we could connect people who we were asking to quarantine or people who we were asking to stay out of work, to food, to diapers, to support. And our model is one that doesn't just look at a pure medical model, but comprehensive. What does a person need to thrive and to be in health? So as part of, we learned that from all of these other epidemics we battle around the world. So we incorporate that as part of COVID to say, you can't just do contact tracing or testing or even vaccination at this point. You have to address all of them at the same time, and also look at where is the community in doing this. And I think the US failed miserably in our COVID approach because we don't have a functioning public health system. And we don't have a public health system because we've defunded it for decades. So there's amazing public health nurses who are usually one person in a small town or in city who have been in existence for a long time, systematically defunded for years. And then we wonder why, when something like this happens, why there can't be a response. So we've initiated hiring and working with the mayor's office in Montgomery, Alabama, to hire community health workers and to respond to COVID. We learned that from Ebola and from COVID and from every other, situation that we address globally. And in Immokalee, Florida, which is a migrant community, we have the same thing. We have community health workers who speak those languages of Creole and Spanish who are going, know the community. We hire people from the community. And really, that's the way you do a strong public health response, is it really has to be centered around community focus and a comprehensive model. It can't be just saying, just get vaccinated or just get tested or give me the list of names of who you're with. We have to treat people as part of a community. And that takes an investment beyond just a one-off thing. So I think that Rwanda's had a very successful COVID response and vaccination, and some of those lessons are now certainly being utilized in Chicago. We're working in Chicago with community-based organizations. So it really is the experts around the world of Partners in Health of really seeing that there's a cure to injustice. And that is very much this approach of a comprehensive model that also looks at who has been disproportionately impacted and how do we ensure and try to fight for access for those people.
Thank you. So if we could talk just a minute, in several of your earlier comments, you referenced safety of your staff, of the healthcare providers. So what strategies did you deploy to maintain the health and safety of your workforce? And particularly if you could talk to the mental and emotional sequelae in the aftermath of, let's use Ebola as an example. You know, our nursing leaders across the country are struggling with this. Our clinical workforce, our nursing workforce is experiencing PTSD and other sequelae of finding themselves in situations that were unimaginable before this. So tell us a little bit about how you address those issues.
Yeah, there were so many parallels. And I think at the beginning of COVID, seeing people make makeshift PPE, it took me back to the challenges we had where we couldn't get PPE and in the protective equipment in West Africa, mostly because the US had bought it all up. And so there was also a huge, I was so angry about a lot of what we were facing because the US just shut down and was, worrying about our own borders rather than fighting Ebola where it was happening, which was West Africa at that time. And there's horror stories about, me coming back and forth and being detained at airports for, 15 hours, that type of thing. And really being subjected and treated like I was, a criminal in many senses. So I think that worrying about the safety of the staff. And, I remember vividly one time having to pull the staff out of the Ebola treatment unit because we'd run out of PPE. And the staff, which is the same thing, echoes of what happens here, said, I'll stay in. And it was very unsafe to stay in more than 1 hour at a time. And you had to come out and be decontaminated before you could, and rest and drink before you could go back in. And we didn't have enough PPE. So when we would pull somebody, we couldn't replace them. But I couldn't send people in because some of the PPE we got was defective. We knew that it wasn't safe. We could see that water could permeate it. So, and luckily we were able to, within an hour, borrow PPE from another place and do it. But I remember thinking I was just as concerned about the patients in that unit, but knew that my job was to keep the staff safe. And from them also wanting to still stay in there to care for their patients. And I had to take a step back and remove myself from that intensity of wanting to care for the patient, because my position at this point was not as a caregiver, but as a manager or director. And that was hard. I think we also knew that mental health, the impact of seeing so many people die was obviously so challenging. And, we have a strong mental health program throughout Partners in Health around the world. And we utilized our mental health team to help. We didn't do it as well as we should have. We didn't do it as quickly as we should have. And, I think looking back, if I was doing this again, I would put mental health as the key component at the very, very beginning, whereas we added it a little bit later, just in our rush to get things going. But I think it's the challenge of what nurses and nurse leaders are going through in this country is just heartbreaking to me, because it's also the waves of, people being perceived as heroes and being the country rallying around. And then to be now in such a situation of it's become so politicized that people are just leaving their job. And, I think this hopefully will be a time of reckoning where we look at our current health system and say, what went wrong in a country that spends the most money by far of any other country? What could we have done to change this dynamic? And I think listening to those in the most proximity, the direct caregivers, because I don't have the answers, but listening to them, I think will lead us on the right path to try to fix this.
Thank you. Thank you for sharing that. So let me sort of turn the conversation for our last few minutes together to the global role of nurses in this important work. So based on your experiences and your scholarship, how do you see the role of nurses evolving on the global front?
Nurses and midwives are the answer, I think, to global health equity, which is what we're fighting for, is really if you're diagnosed with breast cancer and you live in rural Malawi, you should have the same chance for survival as you do if you're in Boston, Mass, and we're going to have a long road to get there. But nurses and midwives are critical to providing, so many aspects of our care. We're by far the largest cadre of healthcare workers in the world. Very powerful if we stand together and if we can find, commonality. And I think that in many places in the world, nurses are not given the same respect that they are in, the US from what our sisters and brothers fought for in the, 60s and 70s, and I've reaped the benefits of. But I think that we have to give nurses the tools to succeed at the highest level. So one of the most, as a new leader within Partners in Health now in 2011, when I went to Haiti one of the first times, I insisted that the Haiti nurse leader be beside me in one of the meetings. And I was invited because I was from, the headquarters type of thing, although we don't have that anymore. But she was asked a question. And what happened is, as nurses, we tell stories exactly like I'm doing now. And so the question about, patients in one of the certain facilities we have there, she kind of was telling an example of a patient to give the information. The physicians at the table shut down within a minute of her opening her mouth and just completely, disregarded her. And it's because they wanted data, they wanted the monitoring evaluation, they wanted her presentation to be in their language. And I thought I failed her as a leader, and we call it accompaniment. We really value I'm learning just as much as I'm giving, and that's still our model all over the world. But I hadn't prepared her to succeed in that setting. So we started very much based on the Executive Nurse Fellowship, the RWJ program that I did. Soon after that, we started a nursing fellowship training to give nurses, how do you do a budget? How do you do monitoring evaluation? How do you present at a meeting? Because many of us never learned that in school. When I first started doing things like this, I called other nurse leaders for other NGOs and said, I have no idea what I'm supposed to do to write this proposal. And we all help each other and we all rise together, certainly as nurses. And so I think that we need to ensure that nurses have the tools to be at the big donor tables and for us to insist that they're there with us. So when I show up to a meeting, I'll always say, who's here from the Malawi Ministry of Health? Who's the nurse leader? I shouldn't be there unless they're there too. And it shouldn't be me giving voice when there's people who have their own voice. It's me sometimes getting out of the way. And I think that that's often a big role I think I have, is often getting somebody to the table and then me not saying a word and letting them and me bringing them with us. And I think that we have a responsibility to each other as nurses, and particularly nurses in the US who are working globally, they need to get out of the way and they can get somebody at the table. And then, when we talk about authorship, we have strict rules about if you publish a paper in Liberia, there has to be Liberians first author, so many, a certain percentage of all of our work and things that are published have to have people from that country as the authors authentically. And so I think there's places where if we promoted all of each other to play this role, I think we could really go such a long way to changing the dynamic of healthcare. But it's a battle because nurses in many places are really left behind.
Well, thank you for that advice. So give us some more advice. So as we think about our leaders, our emerging leaders, educators, researchers, and our students, what advice would you give based on your career if they're interested in a role at the global table? So sort of think about how your career evolved. I'm sure there was a lot of very deliberate planning, but there was also some serendipity that happened as well. So tell us about, how did you progress to get to this really amazing leadership position?
Yeah, it's interesting. I was just talking about this recently with a class, and I always talk about, Spider-Man as my philosophy of career planning, because I didn't have a plan. And I feel like you either have a passion or you have a plan. Some people can meld those together. I definitely, became involved in HIV in the beginning as a nursing student in the 80s when it just was beginning, and became very engaged in the HIV community and social justice as a huge part of my nursing role. So every career move I made was about me following that passion, not that I had a plan to get to a certain place, because there's no way that I could have mapped this out, because part of it's opportunity. Part of it is starting in as a nursing student in the mid 80s and working in HIV. I became an expert really, so-called expert really young. And I found the Association of Nurses in AIDS Care, which was my professional community. And we all utilized each other, across the country to learn from each other because there were no books. And then when there started to be funding for HIV in Africa, for example, as an expert at a really young age, I was tapped to go work globally to pass on that information. And that path couldn't happen today because of just the different circumstances, and nor should it. I mean, it was definitely a point in time that it shouldn't have been that HIV treatment was decades behind in Africa than it was in the US. So I think my advice is, find something you're passionate about and follow that, because then you're going to succeed in what you do. Because if it's something that doesn't speak to you authentically, you're not going to be your best self. So briefly, for a few weeks when I was working as a nurse practitioner at Mass General, and I was a single mother and very stressed and never had enough money, and I thought, I'm going to work for a pharmaceutical company because we were so sought after. And I lasted 3 weeks. And I literally just stopped going to work. And I just said, this isn't working. And luckily I had stayed at the clinic, and then they ended up taking me back. But I thought, that was a good lesson early in my career that, the money will figure itself out. But if I'm not passionate about it, I'm not going to be a leader. So had I gone that route, and there's amazing nurse leaders in pharmaceutical and corporate and industry, but that wasn't my passion. I would not be a leader today if I had gone that route. Because I thrive, as we all do, when we're authentically connected. So I think it's, my advice always is find that passion and then be open to opportunities. And I think that many of the opportunities I've had, part of it is you just have to throw yourself in there, like volunteering for the Ebola thing, putting my hat in the ring for the CEO, which, is really on paper would make no sense. But I think it's looking to see where you can do good and follow that passion and contribute to something that's important to you. And then I think that you thrive as a leader.
Well, thank you. First of all, on behalf of all of your nursing colleagues who are listening into this, thank you so much for being the leader that you are and inspiring all of us in terms of our leadership and scholarship to aspire to do many of the things that you've described here today. I'd like to thank you so much, and let's stay in touch as your career, as your projects continue to evolve. We would love for you to continue to stay part of our larger nursing economics community.
Yes, no, thanks so much for the opportunity.
Great. Thank you, Sheila.
Thank you.
The Nursing Economics podcast series is owned and produced by Genetti Publications, Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Sheila Davis is the Chief Executive Officer of Partners in Health, a nonprofit social justice global health organization that brings the benefits of modern medical science to impoverished communities in 11 countries. With a staff of over 19,000, Partners in Health works to ensure that the universal human right to quality health care is realized. Dr. Davis has a long history of serving the poor and marginalized, starting with her work with the HIV/AIDS community in the 1980s, both in the United States and abroad. She was a clinician in the Infectious Diseases Clinic at Massachusetts General Hospital for over 15 years, and for the past decade has held multiple cross-site roles at Partners in Health, including Chief of the Ebola Response, Chief of Clinical Operations, and Chief Nursing Officer. Dr. Therese Fitzpatrick is a Senior Vice President at Kaufman Hall and a member of the Performance Improvement Practice specializing in workforce strategy. She is also an assistant professor in the School of Public Health at the University of Illinois, Chicago, and is a member of the Nursing Economics Editorial Board. For archived episodes of this podcast and to learn more about nursing economics, visit the journal's website at nursingeconomics.net. You can also subscribe to the Nursing Economics podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found. And remember, as a listener, you can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net, click subscribe, and enter promo code NECSAVE50 to take advantage of this special discount.